Good morning, friends. We're gonna learn about endometrial hyperplasia today. Endometrial hyperplasia. Why does this happen? What do you mean by endometrial hyperplasia? As we know that uterus has three layers, which is endometrium, myometrium, and the perimetrium. Endometrium is the innermost layer of the uterus. So endometrial hyperplasia uh, means nothing but proliferation of uterus. Why does this occur? It occurs due to the increase in estrogen. Okay, so as there will be the proliferation of the uterus, the female will come with the complaint of atypical uterine bleeding. So atypical uterine bleeding may be divided into three age groups. It may be in reproductive age group, it may be in perimenopausal age group, or it may be in menopausal age group. Age group. Okay, so what will be the first step if the patient comes with a atypical uterine bleeding or if we are suspecting endometrial hyperplasia? So for menopausal age group, we'll directly go for EV scan. Okay. And for reproductive age group and perimenopausal age group, we'll first do urine pregnancy test. Because as we know that in pregnancy, there may be increase in endometrium. After doing feeding, the results may be positive or negative. If it's positive, then she is pregnant. And if it's negative, then the next line of the investigation would transvaginal sonography, which is TVS. Why do we do TVS? TVS first we do to rule out other pathologies, and secondly to see the thickness of endometrium. So basically, if there is any patho, firstly, if there is any other pathology due to which UB is happening, treat it. Secondly, we see the endometrial thickness. So, endometrial thickness in reproductive age group, if it is more than 12 mm, then she may have high risk of endometrial carcinoma. And she is a perimenopausal age group. We should always say that she has a high risk. And if she is menopausal, if it's more than 4 mm, she has risk of CA carcinoma. So what if a reproductive age group people come with the endometrial thickness of more than 12 mm, or if the menopausal comes with the endometrial thickness of more than 4 mm? If the reproductive age group female comes with eating more than 12 mm, and the menopausal comes with a more eating.
if the reproductive age group and perimenopausal age group ET is more than 12 irrespective of the age group of perimenopausal women, we have to do endometrial sampling. So endometrial sampling can be done by two ways, which is the first one is endometrial biopsy, and the second method is endometrial aspiration cytology. Aspiration cytology. So endometrial aspiration cytology is further divided into two types. It can be done by Carmen's cannula, and it can be done by Pepel's aspiration. So after doing endometrial sampling, we'll get the report of the endometrial sampling. So the report may suggest of endometrial hyperplasia without atypia and endometrial hyperplasia with atypia. What if the report says it's endometrial hyperplasia without atypia? Then we can go with the further management of the treatment. So the management of the treatment would be, the drug of choice would be progesterone. So how can we take this progesterone? Progesterone can be given in two ways, one by implant and secondly by orally. Implant, we can give Marina, and orally it can be given in two ways, which is a continuous way or a cyclic way. So in continuous way, it can be given on the 12 to 14, it should be given for 12 to 14 days in a month. The oral progesterone which we give is Megestrol 40 mg BD, and or else we can give medroxyprogesterone acetate, 10 to 20 mg BD, 10 to 20 mg BD. And what if the symptoms persist, like if the bleeding is persisted, or during the follow-up, which is the follow-up which is done every 3 to 6 months for 1 year, if the bleeding persists, or if endometrial hyperplasia without atypia persist. That's what if endometrial hyperplasia without atypia persist. Or bleeding persist, which is atypical uterine bleeding, or there may be another outcome where it may change into endometrial hyperplasia with atypia. Or if it so for the next line of treatment where the bleeding persists and without atypia persist, we do DNC plus hysterectomy, which is dilatation and curettage plus hysterectomy. Note that functional curettage plus hysterectomy is preferred more than dilatation and curettage plus hysterectomy. But as it is easy for dilatation and curettage to do, we prefer it more nowadays. Next, for management of endometrial hyperplasia with atypia, the treatment of choice is hysterectomy. If it is a menopausal woman, we'll do total abdominal hysterectomy plus bilateral salpingophorectomy. And if it is a perimenopausal woman, we prefer total abdominal hysterectomy. And what if the patient refuses for hysterectomy? Not done. We can give Marina. We can put them on Marina and ask them to follow up every 3 to 6 months for 2 years. And still, if the bleeding persists, then hysterectomy should be done. There's no other option for it. Should be done. Thank you guys. I hope you like this lecture on endometrial hyperplasia.